Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Hello, everybody, and welcome back to Airway Answers. Again, I am so excited with our guest today, Dr. Rakesh Bhattacharjee. I feel like I'm a little nervous, Dr. Bhattacharjee. I've been waiting to do a podcast with you for kind of a few years now, and I'm like, this is the day. So thank you so much for being here.
Well, thanks for having me, and that's flattering and also embarrassing because we live in the same proximity. So
I know.
Should have done this a lot sooner.
So funny. I've known Dr. Bhattacharjee actually for quite a few years now, and I'm so excited for you all to meet him. I think probably a lot of our audience actually knows you already or doesn't realize they know you because they are definitely aware of some of your research that we are going to go over today. But I met you, it was 2014 or 2015 in Chicago at the AAPMD conference and the AOMT conference back then. And There was an announcement, you did a presentation, and at that point you were moving from Chicago to be the head of the Pediatric Sleep Apnea Clinic at Rady Children's Hospital in San Diego. So I had my little binder with me, and I don't remember the exact year. Do you remember when that was?
Yeah, I think it was it 2015 or no, it was 2014 because then I also spoke in Los Angeles, I think the following year.
Okay. I remember
I think I'll tell you there as well. And that was so because I've now been in San Diego since 2015, so we're over 10 years now.
Okay. And maybe you had already gotten to San Diego at that point. I don't know, but all I know is it was freezing cold because it was Chicago and it was the winter. It was freezing. And number two, when I saw you did a presentation, I'm like, I got to track this guy down. And I ran and chased you to introduce myself because I'm like, we're in the same area. So it's been great. We've collaborated a bunch, and I'm really excited for this interview today because you are a pediatric pulmonologist and a sleep medicine physician. And there's two pieces of research that you have that I cite often. One that I've been citing more often because it's from 2010. It was a study, I believe you were the lead researcher, and also Dr. Gozal and a bunch of other people were there. And it was a study, a multi-center study of 578 children with obstructive sleep apnea who underwent tonsil and adenoid removal surgery. And this was really important findings for all of us in the medical, sleep, dental medicine field, because what you showed in that study was that the sleep apnea significantly improved for most of these children, nearly all, I believe 90%, but only 22.7% of these children who underwent tonsil and adenoidectomies had complete resolution of their sleep apnea. So 72.8% still had some residual sleep apnea. And we're going to talk about that today because that relates a lot to myofunctional therapy and craniofacial anomalies and possibly obesity and other factors. So I really want to talk about that because I always cite that research and talk about how tonsil and adenoid removal might be a very necessary and important step in this treatment process, but it might not be the only thing. There are other factors. So we're going to go over that. And then we're also going to talk a lot about a study probably all of my colleagues are aware of. You just published in May 2026. So just recently, just this year. And this was a research study along with other people we know, Dr. Judith Owens, Dr. Herman Ramirez, Stephen Olmos, lots of people who are very well known. And this was examining craniofacial risk factors for sleep disordered breathing in children seen in routine dental practices. And we're going to talk all about that. That is very important for all of our colleagues to be aware of. But what you found in that study was there are significant associations between an increased risk of sleep disordered breathing and particular craniofacial findings, such as narrow palate, open bite, heart-shaped tongue representing tongue tie, and most strikingly, for those of us in the myofunctional world, tongue thrust had the greatest association to risk factors for sleep disordered breathing. We got to dive into this. I am so excited. So let me actually go over your bio, and we're just going to talk, and I'm going to ask you everything I can in the
please
short
do.
amount of time we have, because you have another meeting right after. So before I go over your bio, again, I really thank you, Dr. Bhattacharjee, for being part of this interview today.
And I want to thank you, Nicole, for really spearheading the effort to think about alternative strategies in the domain of sleep disorder breathing, which historically has been a surgical treatment. But the more we've uncovered in the last 20 years, it's really not just surgical. We really need to keep our minds open, because this idea that one shoe fits all doesn't really work. And that's kind of really been my MO since I've started sleep, is to understand how there are different phenotypes of sleep apnea, and we need to do better. And that's what led to our recent publication that Saini from Boston helped spearhead, for us to understand how we can engage our dental colleagues to better phenotype these patients.
This is amazing. This is wonderful. And hopefully we'll have some time also to talk about other factors like restless leg syndrome, periodic limb movement disorder in relationship to ferritin or low ferritin, CPAP in children, other things that you address with your patients. So Dr. Rakesh Bhattacharjee is a pediatric pulmonologist and sleep medicine physician who serves as director of pediatric sleep medicine in the Center for Healthy Sleep at Rady Children's Hospital, San Diego, and is also professor of pediatrics at the University of California, San Diego. Whoop, my alma mater. He earned his medical degree from McMaster University in Canada and completed his pediatric and respiratory medicine training at the Hospital for Sick Children at the University of Toronto, followed by sleep medicine training at the University of Louisville. Prior to coming to San Diego, Dr. Bhattacharjee was on the faculty at the University of Chicago's Comer Children's Hospital. His clinical and research work has focused extensively on pediatric obstructive sleep apnea and sleep disordered breathing, including the cardiovascular and metabolic consequences of OSA, obesity, persistent OSA following adenotonsillectomy, positive airway pressure therapy, and strategies for improving the diagnosis and treatment of sleep disorders in children. He has contributed to a large body of research, I believe over 90 publications you have, examining not simply whether a child has sleep apnea, but how sleep disordered breathing can affect the developing child and how we can better identify and treat children who remain symptomatic despite traditional interventions. That is a big, important sentence, because like we just said, one shoe doesn't fit all. These problems are multifactorial, and we need to address all contributing factors. So I do want to start out, Dr. Bhattacharjee, just talking about you a little bit and how you became interested in pediatric pulmonology, sleep medicine, and I know you have a specialty area in pediatric obesity, and how that all developed for you.
Yeah, so one thing that's been a challenge, at least in the space of sleep medicine and pediatrics, it's not really a core curriculum, at least when I was training. I essentially stumbled across sleep during my pulmonary fellowship. I was always interested in pulmonary physiology and research in pulmonary vascular biology, which led for me to embark on a fellowship in Toronto in pediatric pulmonary medicine. But it was actually a few things that happened for me. It was patient care driven. It was also a grand rounds given by my mentor, Dr. David Gozal, who really opened up my ideas about how this notion of the connections between the brain and the lung can be established through a field like sleep medicine. And really one of the first patient encounters that I had that made me discover the importance of sleep disordered breathing was really understanding how, if you have disordered breathing during sleep, how that affects the host. So the patient that I saw, believe it or not, actually had a frank insomnia. They were scared of sleeping because of such severe sleep disordered breathing. And while I was very fixated on pulmonary physiology, I started uncoupling the notions of how the brain and the lung can interact. And the best way to prove that interaction is by actually understanding sleep physiology. And so that's what led me to doing a sleep fellowship, which at the time was not available in Canada. And I left to Louisville, which was the place that Dr. Gozal was the program director, and I did my fellowship there. And that really opened the doors in terms of understanding sleep apnea, understanding behavioral sleep, understanding sleep hypoventilation, but also looking at how translational sleep medicine can be. It's especially in sleep apnea, which can sometimes be thought of as an inflammatory disease in pediatrics. It can be a cardiovascular disease related to obesity. So there's really just created a whole wealth of knowledge, but also just gave me so many questions to ask both Dr. Gozal, but myself in terms of research questions. And ever since that decision to go there, I've had no regrets. I love what I do. I love seeing how we can optimize sleep for our children, how parents are now more vested in sleep, how providers like yourself can make a huge difference for how kids sleep and see the repercussions of good sleep, which is really what I think we need to do as a society.
I love what you said, the brain and lung connection. I've never heard of it that way, but wow, think about that. The connection between breathing and the brain. We all think about that. The brain lung connection, though, is a really good way to put that. And that's interesting that your first case that really delved you into that was a child who actually had insomnia due to the sleep disordered breathing for fear of going to sleep. And we hear about that in our pediatric and adult patients where there is that sleep initiation insomnia and the body is fearful of sleeping because it might be choking all night. So
Right.
That is a real thing, huh?
That is a real thing. It's also a real thing to see parents becoming concerned and stressed and even anxious about their children who might be struggling to breathe when they sleep. So there is this new entity that we call COMISA, or comorbid insomnia with sleep apnea, that has been well ascribed in adults. We presented at the American Thoracic Society this year about COMISA in children and the fact that it was actually very highly prevalent in a sleep clinic, but even more prevalent in the ENT clinic. That a lot of these kids who come in for snoring start developing tendencies where they don't know how to fall asleep well and stay asleep well. And it's becoming a concern of mine because, when we, again, going back to the brain lung connection, we try to treat breathing with the lung and the upper airway, but we also need to realize that there might be comorbid aspects of insomnia that we also have to deal with. And one thing that I stress to all the trainees that we have here in San Diego is that if you're thinking about a career in sleep, whether that's as a psychologist, as a myofunctional therapist, as a physician, you've got to think holistically. And you've got to think of how sleep can have so many different impacts on different functions of the body. And a classic example just would be like that first child that I saw who was scared of falling asleep. Now I have parents that are worried about their kids. So we really need to tackle this with an open mind and a holistic sort of lens.
Yeah, it's a family problem. Exactly.
Correct.
And whether it's adults and the spouse is snoring, keeping the person awake, or whether it's a child and the parents are worried and concerned. So it is definitely a family or a systems model. And when we talk about COMISA, I'm actually curious, that fear of falling asleep or that insomnia, I would assume this is a subconscious pattern the brain has developed. It's not like the person saying, I don't want to go to sleep because I'm going to be choking. The brain subconsciously develops that fear. Is that correct?
Well, it can be that. It can also be this idea that you always think that you're not going to get a good night of sleep. So you start becoming conditioned where sleep is a struggle. And the root cause for these patients with COMISA is sleep apnea. Right. So if you fix the sleep apnea, you intuitively think you should fix like the stress that you have. But there are individuals that start conditioning their brain thinking that sleep is stressful. I'm not getting a good night of sleep. And parents, for example, I'll give you, I saw a child yesterday that had 3+ tonsils. Child wakes up at night because of obstruction. What happens? Child goes into the parent's room and now they're used to sleeping with the parent and they don't know how to sleep on their own, right? And so this is how sleep apnea can lead to what we call sleep onset association disorder, where now sleep for that child, yes, they're snoring, but there's also this component that I only sleep with my parent. And so we've got to we've got to tackle both of those
I
problems.
completely know that. I just reviewed that with a friend, similar issue, and it's that classical conditioning factor.
Correct.
And now I'm totally going off topic with my questions.
Okay,
And I have all
no
these
problem.
questions for you, and I'm like, no, I'm going this route because it's interesting. So I know for adults, cognitive behavioral therapy for insomnia is highly effective. Do they do CBTI, cognitive behavioral therapy for insomnia in children?
They do, yeah. So there is one thing that since that publication in 2010, where we looked at sleep apnea, and I'll tell you why I'm talking about that publication. There is my belief that we in pediatrics see two types of sleep disorders. We see sleep disorders for sort of the young child and sleep disorders for adolescents. And if you think about insomnia, insomnia for the adolescent is very different from insomnia for the toddler that can't fall asleep. And it's very different in the sense that for the toddler who can't fall asleep, our psychologists actually work with a parent to help them sort of quote unquote sleep train them. But for the adolescent, we work with the adolescent, and that's where CBTI becomes key, is because we need to recondition those adolescents. So very similarly, I'm a firm believer now that adolescent sleep apnea is very different from the toddler sleep apnea. And my colleague, Dr. Diet, once gave us sort of these two types of sleep apnea, which is mostly obesity focused. But I do think there's a type of sleep apnea that's adolescent focused, where we need to think about other parameters that's contributing.
Okay. Other factors that have maybe developed over time.
Yeah.
Potentially.
Correct.
Okay. And since you just mentioned the 2010 study, that would be great to jump to that, because this study, so I actually have a slide I present, I talk about this, and I'll just kind of say a little bit about it, and then I'll let you get really into it. But the 2010 study, it was a great size study, 578 children from 8 pediatric sleep centers, 6 were in the United States, 2 were in Europe. And these children underwent the sleep study before and after getting their tonsils and adenoids removed. And you found that surgery did provide a substantial improvement for the majority of these kids, and that AHI improved 6, 12, 24, 36 months post tonsil and adenoid removal. But you saw a progressive worsening of the AHI at 3 years post surgery. And also 72.8% of the children had residual sleep apnea after having their tonsils and adenoids removed.
Right.
You know, tonsil and adenoid removal is kind of the gold standard treatment for pediatric sleep apnea. When I do present this, I do talk about how there are other factors like what we're discussing, and that might be one necessary component. But we also need to treat the structural piece. So whether there's dental orthodontic comorbidities, which oftentimes there are, like narrow palate, maxillary mandibular hypoplasia, and also the oral muscular patterns, what we address in orofacial myofunctional therapy. One significant piece is mouth breathing, open mouth breathing. So can you talk about that study, those findings, and what caused that OSA to not resolve in such a huge percentage of those children?
Yeah, so this was a retrospective study, and as you mentioned, I had the privilege of being able to see sleep studies before and after surgery. And our primary outcome was the apnea-hypopnea index, which we in the sleep world use as our sort of be-all, end-all for deciding what sleep apnea is and isn't. Although recently has come to some controversy, is it the only thing that we should be looking at? And that's a topic in itself. But using the apnea-hypopnea index, what we found was what was predictive of your post-surgical apnea-hypopnea index. The strongest factor was actually age. So the higher the age, the higher the post-surgical AHI, which signifies that perhaps we need to think about surgery to a different limelight when it comes to kids who are older that have sleep apnea. Whereas younger kids, in fact, surgical response was pretty robust. Okay. Now, when I was actually thinking about that study at the time, the idea that I had, the hypothesis that I had is, okay, it's clearly going to be obesity that drives residual sleep apnea. And it's clearly going to be the more severe your sleep apnea is, the more likely you're going to have residual sleep apnea. And we did find that. We found that obesity was a predictor, and we found that the more severe your sleep apnea was before surgery, that was also a predictor for residual sleep apnea. But again, beyond that, we found that advancing age was an even stronger predictor. So how does this all sort of come together? So one, young kids, very young kids who have big tonsils probably will have a very good response to surgery, even if they're obese because they're young. Whereas the older kid who has big tonsils may still have residual sleep apnea because there are other factors that are contributing to sleep apnea in the older kid. It could be that they're obese. It could be their jaw structure. It could be muscular components that are contributing. And I want to emphasize that when we think about young kids and adolescents, like you've heard me already describe that there might be this idea of a dichotomy here. And the reason there might be a dichotomy is the adolescent airway these children have almost maximized their growth. They've almost already gotten their actual adult height. When you get there, your adult height, that means your airway is fully grown. So if you have sleep apnea with an adult airway, your tonsils might be contributing, but you might be thinking there's other components that's leading to that. And so you really need to think a little bit more beyond adenotonsillectomy. Now, I will say, though, that doesn't mean that older kids don't benefit and they're not cured by adenotonsillectomy. In fact, some adults can have their tonsils taken out and their sleep apnea is resolved. It just shows you that it becomes more complex and there's much more contributing to sleep apnea as you get older. And I think one of the things that I marvel at that we really need to understand is, and especially in the field of myofunctional therapy, how much does doing this early have an impact on that trajectory later in life? This is sort of the $1 million question, is can we actually do something early in life that's protective to prevent sleep apnea as you get older? And I'd love to hear your thoughts on what you think about that question.
Yes. No, I think this is great because this is all vouching for early intervention.
Right.
I do want to ask you the age when you say younger age versus older. Is older, you're talking about just adolescent age that had residual sleep apnea, or what kind of age group would you consider younger versus older?
Yeah, so in that paper, statistically, when we used receiver operated curve analysis to look at what age was most predictive of residual sleep apnea, it was age over 7. Okay. But as you get older in that cohort, the risk of sleep apnea or the higher AHI goes up.
Okay.
Now, I will say that when you quote 72% of people had residual sleep apnea, that in itself is because we use our primary outcome of an apnea-hypopnea index of less than 1 being normal, right? In our paper, we found the vast majority of post-surgical apnea-hypopnea index fell in the range of 1 to 5. And about 22% had an AHI over 5. Now, we use these thresholds. Some challenge them. Insurance companies have thresholds that they decide when we can start something like CPAP. The gestalt in pediatrics is we think moderate sleep apnea, which is an apnea-hypopnea index over 5. We found that prevalence was 22%. So now what we tell everybody, no matter their age, that you have a 1 in 5 chance that you probably still need some further therapy. And then the patients that fall in the 1 to 5 group, the mild OSA, well, that's the next hot topic. And you probably are familiar with the PAT study where they targeted the kids with mild OSA just with surgery to see if that makes a difference. And that's kind of the next area of struggle that we have, is what do we do with these patients that have just mild OSA? What's the next best step for them?
Right. And when you say age 7 is that older age group, that still feels young, right? And a lot of our kids aren't even having tonsil and adenoid surgery till 7 or later.
Correct.
So it's not, I don't know how common it is for children under 7 to have their tonsils and adenoids removed versus 7 and older, what the percentages are, but really it vouches for early intervention, early identification. And when you talk about myofunctional therapy and its role, we know myofunctional disorders are progressive, right? So if left untreated, they're going to get worse or somewhat stay stable. It's not, they don't typically just resolve on their own. And the impact of that soft tissue dysfunction on the craniofacial structure is also going to be ongoing. So if the tongue is not supporting the growth of the palate, the transverse, and the AP growth, then that also is going to have impacts as well. So perhaps those older age groups are having poorer outcomes because the soft tissue and structural factors are just getting worse as they get older. It's kind of more factors, right, are building. And there are studies showing that, like you said, tonsil and adenoid removal, the majority of children do get better, right? They do, but it might not completely normalize their breathing, but the majority do get better. And adding myofunctional therapy to any treatment program tends to help that treatment become more effective. So there's studies showing that what I present on when I'm presenting on myofunctional therapy is that there's a high risk of sleep apnea relapse in children when they're in their teenage years, where they once thought that the issue was resolved. So maybe age 7 or 8, I think it's kind of, I forgot the average age in that study. The average age might have been about 7.5, where they had tonsil and adenoid removal and rapid palatal expansion, sleep apnea resolved. And then there was relapse during the puberty years, because like you said, that's sort of the age where the airway is kind of stopped growing. And also they account for, in males, the tongue grows during that time period. And they showed that when they added myofunctional therapy to the treatment plan of those receiving tonsil and adenoid removal and rapid palatal expansion and adding tongue tie release for those who were diagnosed with a restricted lingual frenum, that could help prevent relapse during the teenage years. So those children where myofunctional therapy was an added component, those children did not relapse.
This was the data from Italy, from Maria Piavilla's group.
That's one of the studies, and I got to pull up my PowerPoint, but I wasn't prepared to cite those studies, but there was another study, and I have to just look up the year. And
it goes to show that the next sort of phase of sleep medicine, at least amongst sleep physicians, is to pick apart those patients that we can see a clear benefit that would need like more individualized or phenotype driven therapy. And this is becoming very paramount in the other aspect of sleep apnea, which is obesity. Because now with the SURMOUNT OSA trial and looking at Tirzepatide, which has a clear impact in adults with sleep apnea, well, we do know some data, and this is data from a close friend in Belgium, Stan Verhulst, who looked at weight loss. Weight loss can be effective as well to treat sleep apnea. But you now have all of this, and so what we need to do better, which is really what led to the publication that we did that I was collaborating with Julie and Saini and Steve Olmos. So what we need to do better is basically figure out how we identify those patients that we can say, okay, we've got the sleep study, you have sleep apnea. Now, what's contributing to your sleep apnea, and how do we give you the best individualized therapy plan, making use of all the great disciplines that exist at our disposal to manage sleep disorder breathing?
And do you feel that children should receive a follow-up sleep study after they've had tonsil and adenoids removed, and how far after?
Yeah, great question. So we have put into place a program here at Rady Children's Hospital where at very least every child that has severe sleep apnea has a post-surgical sleep study. Okay. And we actually published this QI project. The lead author is Wen Jiang, who's an ENT surgeon. And I've developed an outstanding relationship with the surgeons here looking at that population that has residual sleep apnea. It's become very clear that our approach is multidisciplinary, where we all see these patients in different clinics. And the idea of post-surgical sleep studies becomes more important when we start to identify risks, okay? So if a patient has severe sleep apnea, yes. If a patient is older, probably I would think about it. Or at least these patients deserve some form of follow-up. And if they're older and obese, I more likely say, yeah, because I think the obesity is also contributing to your sleep apnea. Yeah, I think the tonsillectomy will help. but we got to be sure if it's resolved, because if it's not, then we need to think about either positive airway pressure, weight management, or alternative strategies. What we're struggling with, Nicole, is those patients, because none of us are formally trained in the mouth, right? This is what we need to do better, is when we see that child has tonsils but might have some retrognathia or might have some myofunctional limitation, maybe that child probably should have a repeat sleep study, because tonsils are doing one thing, but it's not addressing the habits of the mouth, the habits of the jaw, why this kid is an obligate mouth breather. So that's kind of why we need to develop sort of these ideas where we have like maybe a questionnaire, which is what Steve almost sort of developed, where we can say, okay, this patient has a high score for limitation from a craniofacial perspective or from a muscular perspective, that we should probably repeat the study just to make sure that they don't have a suboptimal response to adenotonsillectomy.
Yes, and I definitely want to talk about that study in a minute. So repeating the sleep study, there's usually, I assume, a wait list, could be months, and what is the timing of that repeat? But I think the majority of these children who have enlarged tonsil and adenoids, and probably the majority who have sleep apnea for other reasons, also have craniofacial anomalies. The tonsils, when they're enlarged, can impact functional tongue space at the back of the throat, causing that tongue to rest low and forward. Not all of our enlarged tonsil patients are mouth breathers, because it might not block the nasal airway, right? But it's going to impact tongue resting posture and functioning, thrusting, because those large tonsils. Then when we have enlarged adenoids, that can block nasal breathing, so that child or even adult can become an open mouth breather. So when we open mouth breathe, we have low tongue posture also. So probably the majority of these patients, I would never say all, but I want to say all, have a myofunctional disorder. And my thought is, repeat the sleep study if you want. I don't know, but they should be referred right for myofunctional therapy to evaluate whether there is incorrect oral rest posture, low muscle tone, open mouth breathing, or just nasal breathing below tongue posture, and see if those need that type of treatment. And then always our sort of trifecta is medical system, which we're talking tonsil adenoids or tongue tie or whatever, myofunctional, so muscular system, and also the dental skeletal component. Right. So a lot of these kids also need expansion and forward growth of the jaws, and sometimes increased vertical dimension because they don't have enough of that vertical space, or they've ground down their teeth, and that's why that space is reduced. So it's such multiple systems thing, like we're talking about, that repeating the sleep study, I guess, will show the severity, but even those mild or subtler forms or more upper airway resistance, are those going to get caught? And is it worth waiting for a sleep study? And that whole piece, when I believe there's probably a high likelihood that there's other myofunctional and dental factors going on. So this leads me to want to talk about that recent study that was released, and that went all over social media. You probably know, I don't know. I mean, all of my dental colleagues, everybody was sharing this, and it's titled Pediatric Craniofacial Risk Factors for Sleep Disordered Breathing in Dental and Orthodontic Practice Settings. It was an observational pilot study released May 2026. And what you showed was there is that increased sleep disordered breathing risk associated with, and I'll state the numbers and then I'll love for you to go into detail on this. But let's test my knowledge and my notes here. And I just recently also presented on this. So this was that study with Stephen Olmos, Dr. Judith Owens, and Dr. Herman Ramirez, and 20% of the children screened were at increased risk for sleep disorder breathing. 20% screened in the dental and orthodontic settings. And what the findings individually were is narrow palate shows 3.5 times increased odds of sleep disorder breathing. Open bite, 5.6 times the odds. Heart-shaped tongue, 7.4 times the odds. And tongue thrust, 11.3 times the odds of having increased risk for sleep disorder breathing. So can you talk about this study?
So this was an important study for us in the sleep medicine space, and it was a wonderful collaboration with colleagues in Boston. But it was also a wonderful opportunity to work with a leader in craniofacial and dental sleep, who was just in our backyard here in San Diego, who's now retired, but he's just always been passionate about looking at this from an academic point of view. The main takeaway from this study is, Dr. Olmos developed a tool that Judy, Saini, and I were kind of interested in the sense that, well, how do we capture sleep apnea in dental clinics? Like, is there something that can be done to give us a sense that these are the gatekeepers? These patients are being seen routinely for craniofacial reasons, whether it's just like looking at tongue posture or whether it's looking at palate. And do those examinations, can they be predictive of sleep apnea and guide us to that next step? So the first thing we wanted to do was we wanted to see how reproducible this was, because everything in medicine and probably the same in dentistry is sort of the eye of the beholder. It's subjective. It's what you see. It's what you believe, right? So we wanted to see if this questionnaire would be reproducible so that we could put it out in prime time, okay? Now, one of the challenges of the study, and this is the challenge really anywhere, is that we relied on another questionnaire for your risk of sleep apnea, but this was a very well-validated tool called the Pediatric Sleep Questionnaire. And while we didn't use sleep studies, we used parents' opinions, subjective opinions about sleep apnea risk. And lo and behold, we found that what our dental colleagues were seeing was predictive of potential risk for having sleep apnea. Well, reviewer will say, well, what's the next thing you should do? You should see if this tool actually predicts what you see in the sleep study, right? This is just a risk for sleep apnea. It doesn't give us a sense of the severity of sleep apnea and what have you, but it is our first step to show, and in my opinion, prove that our colleagues in dentistry can actually triage patients that should get further workup for sleep apnea, which may include sleep apnea testing through like a polysomnogram. So I think it was a nice collaboration showing the importance of how sleep has become a multidisciplinary approach. This was mostly craniofacial, Nicole. I always think one of the big challenges that we all have is capturing like the degree of myopathy, like the degree of weakness, that because nobody can unless you're using measurements, whether it's a Miller catheter or more other measurements of P-crit or critical closing pressure, we really don't know that. And that's the one thing that becomes a challenge, particularly in our patients with underlying neuromuscular weakness. But at least from a craniofacial phenotype, we can at least come up with this idea of, yeah, this is the patient that was seen in the dental clinic. Their screening tool suggested a high likelihood for sleep apnea. Let's take it one step further. Let's refer them. Let's see what their sleep study shows. And then the follow-up to that would be, okay, if they do have sleep apnea, could we now hone in on craniofacial approaches in addition to surgical approaches to treat their sleep apnea? So every research study leads to more research questions. And I think the most exciting part of this was the collaboration that we all put out to come up with this paper.
Yeah, I think it's a really important paper. And so you use the Pediatric Sleep Questionnaire to determine whether they were at an increased risk of sleep disorder breathing.
Right.
And the factors that these dentists, and was it also orthodontists were checking for?
These were, I think this was across dental clinics through Steve's dental clinical programs.
Okay. And did Dr. Olmos come up with like a list of craniofacial factors, and then the dentists were evaluating for those?
Correct. Yeah. And so it was through this basically questionnaire, and we wanted using that questionnaire tool, which was a series of figures actually,
yeah,
to kind of give you a grading. And one of the tasks from this study, in addition to looking at its ability to correlate with the pediatric sleep questionnaires, we wanted to see agreement. Like this is like, for example, like we in the sleep world and in the ENT world, we use the Brodsky score to stage tonsillar hypertrophy, right?
Mm-hmm.
Thankfully, there's only 4 scores, but even then, that can be somewhat subjective. And so we wanted to see, like, does that sort of similar limitation apply? And there was a good degree of reproducibility, which, again, this was sort of the first study, hoping that this will lead to new studies where we can actually use this tool in the sleep lab to see if it's predictive of what we're finding from the polysomnogram.
Yep, let me share my screen too, because I do have that
Yeah, there it
picture
is.
pulled up. Pediatric craniofacial screening for risk of sleep disorder breathing. Can you see that on your screen,
I
Dr.
can. Yep.
Bhattacharjee?
Yep.
Okay, so those were the factors. Now, was this just based on observation by the dentist, or were they actually measuring palatal width? And
This was mostly based on, this was mostly based on observation and
okay,
whether they met these sort of criteria on the right. So
okay,
you would score it based on, did this patient, for example, is this crowding of teeth, is there crossbite? So sort of a checklist
okay.
based on what you saw qualitatively.
And for those of our viewers who are actually just listening on an audio podcast, I'm going to read these because it's important, and you guys can find this online as well. But the factors they were screening for were retrognathic mandible, open mouth, posture, convex profile, and there's also pictures here so you can see these. Mid-facial deficiency, flattened cheeks, concave for the facial characteristics. Dolichocephalic, frontal asymmetry, forward head posture, rolled shoulders. So we're looking at postural and facial features, and then crowding of teeth and crossbite. Narrow vaulted palate or crowding of upper teeth. Narrow palate, open bite, tongue thrust. And there's photographs of all these. Crowding of the lower teeth, narrow on the lower jaw, heart-shaped tip of tongue, and tongue tie. So then those factors that were most associated that match that PSQ were the ones I had listed before. So I think this is great because it is showing that routine dental and orthodontic screening may help identify children at risk, right? It's kind of like we already know this, but this is just helping support that.
Right.
Do you think there's going to be a follow-up study where then those children will go into sleep labs, have sleep studies as another part of this study? And then you can have this screening tool, or is this screening tool something that can be used right off the bat?
Yeah, I mean, that's the idea. That would be the next phase, is like, what do we do with this data, right? Again, there was two parts to this. Like, one, just to see how it associated with the pediatric sleep questionnaire, and is there this relationship, and what of that tool had an association, like the heart-shaped tongue, for example, or tongue posture. But we also wanted to think about what from this tool is there going to be a lot of disagreement. For example, the facial asymmetry, the level of agreement wasn't very good amongst our dental colleagues. And again, like it's a very subjective measure, right?
Right.
So, but the preliminary findings from the study, at least with the association of the PSQ, certain traits of that dental exam is probably associated with sleep apnea. Now, like, you want to do this at a larger scale. You want to do this with a better tool like a sleep study. You want to do this in a non-dental population, right? Just because this is a dental population. So they might be seeing these dentists either for routine screening or for actual specific issues like malocclusion. So to make it sort of prime time, all of these things need to happen. But I think we're getting there. I think it's exciting that we now can rely on our dental colleagues to refer patients that have a high risk for sleep apnea. And then again, like I alluded to earlier, the next question would be, all right, if we do the sleep study and it's positive, do we think a little bit different about adenotonsillectomy given what you found on the craniofacial screening tool?
Mm-hmm. Yeah, adding other factors.
Yeah, and that to me would be the $1 million question, because it helps us better phenotype these patients. The other thing that I want to do, and I wish I had time for this, is I would want sleep physicians to be able to do this tool.
Yes.
Right? Because many of these patients are coming to us by pediatricians. I'm not formally trained at looking at the mouth. I mean, Nicole, don't ask me what number which each tooth is, because I would fail that miserably. Okay, like when I go to my dental exam, they count these numbers. What are you talking about, right? If I want to be the greatest pediatric sleep physician in the world, I think I need to get versed in how to assess the mouth better, and assess posture better, and assess the palate better, because all of these things are appearing to be more and more relevant, at least in my abilities to phenotype patients with sleep disorder breathing.
That is completely true. I'll be there next week. What time is the whole staff free for a presentation?
If you've got like multiple hours to get this in my brain, because
Let's
I
do
always, you know, we offer a complex sleep apnea clinic here at Rady Children's Hospital, and we are lucky to have one of our dental colleagues, Dr. DeBeer, come at sort of on his own to just assess the mouth. We also have our plastic surgeons, Dr. Kanak and Dr. Wasserman, contribute, and I just watched them. I'm like, God, I wish I learned how to do this stuff, because it's so helpful to assess the mouth. And I just don't know the differences. I haven't seen enough mouths to be able to do that. And
yeah, isn't that interesting? Yes, the sleep doctor hasn't seen enough mouths to do that, which is really a great point.
Yeah.
Because the patients you're seeing, they all have a sleep problem. That's why they're coming to see you. Of course, there's non-airway factors, which we can discuss, but probably maybe the majority of them are airway related. Craniofacial related is probably a big thing. And it's honestly not hard at all to identify these facial and intraoral features. And then you are going to be doomed once you learn about this. It is so important because you can't not see it anymore. And your patients are going to walk in the door and you're like, oh my gosh, it's popping out in my face, because these are really easy to see. And someone just needs to have something to teach the sleep medicine doctors, even the ones who work with adults, not just pediatrics, just what to look for, just quick screening. And there are so many comorbid craniofacial factors associated with sleep disordered breathing that are easy to identify and pinpoint, and might add 5 minutes on to a sleep medicine evaluation. So
100% agree. And I think if you can help lead sleep fellowships to teach future sleep fellows how to assess the mouth in a sort of systematic, reliable way, I think we would all be better sleep physicians.
Okay, I'm there. We'll definitely do that. The Ferris Sixth also, I don't know, is that something that is in sleep medicine curriculum or anything at this point?
Not when I hate to say this, because Dr. Gozal did wonders to train me as a sleep physician, but we never really had a lot of dental input at that time. But again, this was like 20 years ago, where now we're caught up. So now is the time to implement these measures to help us. Like we can do Brodsky's, we can do Mallampati's, right? But we are not doing dental assessments to the degree that they deserve to be assessed.
Right. So sleep medicine doctors, even pediatricians can be seeing these things as well.
Correct.
And aren't. I just interviewed a pediatrician. The interview was published a couple of weeks ago, Dr. Eric Valdez in Mexico, in Guadalajara, and he is all airway, gets it all. But he describes how before he knew about this, his oral evaluations for the pediatric population, his pediatric visits, he's a pediatrician, would be taking the tongue to pressure, looking at cheek, back behind the tongue, tonsils. And that was it. He missed everything.
No tongue posture or anything like that.
Tongue and the teeth and the palate, and what does narrow palate mean? And what about open bite or cross bite? Or what if the teeth are angled? What does that mean? The tipping of the teeth, that dental compensation, bruxism, like all those things, they just look right beyond that. And so he talks about how when he became aware of these things, it really changed his practice. Also, I'm on the CAST, Children's Airway Screener Task Force. So the ADA requires all dentists to screen patients for sleep disordered breathing, but most might not know how. So it's a task force for the pediatric population to help identify how dentists develop some universal screening tool they can use. And it goes along really well with your study that we just talked about, where we're going to have a parent questionnaire of just 5 questions that parents will answer at every dental visit.
Great.
And then right now that we're in the pilot phase where they are funding is an issue, but to get these children's sleep studies to see this correlation and what dentists should also be looking for. So that's a big project going on. It takes, as you know, a long time for these projects to go through, but this will be good to coordinate with your research as well, your risk factor screening tool as well.
Yeah, and then the other additional thing about this study, and then collaborations that I had here in San Diego, we have a mutual colleague, Dr. J.C. Stauffer. We're seeing more and more pediatric dentists really thinking about, with their routine exam for a child, I should be screening for sleep disordered breathing. Like, this is my opportunity to intervene. So it's really, we need to both dentistry and sleep medicine, we really need to sharpen our knives to be able to kind of use new evidence like this publication to be able to do better in terms of identifying kids at risk, number one, but two, identifying sort of phenotypic driven treatment interventions, right? Like to date, it's all, you said gold standard, adenotonsillectomy. It remains the gold standard. It's considered the first line of therapy for sleep apnea. But in that seminal publication by Carol Marcus, which she did in 2002 and then in 2012, the difference was we started thinking otherwise about other approaches where adenotonsillectomy may not be the singular focus. And there are definitely kids that have jaw structure that needs to be repaired and could be the primary focus. And so what we have to do is identify kids at risk, at the same time start thinking about what the best treatment platform would be. And when we do that, we want to validate whether our approach actually makes sense, right? Yeah. So there's a lot of stuff that we have to do, but it's exciting. It's an exciting time to really collaborate with all of our colleagues in the space.
Yeah, I believe there's many steps to put this in place because a lot of these things can't just go off clinical evidence, but actually needs to be researched to be put into a protocol and an academic program and to have hospitals implementing it. Right. So even though we might see these things and we know they're true and we see it all the time, there needs to be those steps like what you're talking about. And for the different phenotypes, can you kind of summarize what you mean by that and what you would describe as the different phenotypes of pediatric sleep apnea?
Yeah, I mean, this is a great question, and I know we're sort of wrapping up the end, but I think it's the perfect timed question. So there's two things that I think of when it comes to sleep apnea, right? One, within the sleep study, there are variations of how sleep apnea can present. So we rely on this apnea-hypopnea index, which really merges a ton of evidence, like ton of different parameters to call somebody sleep apnea. That doesn't really give us the granular detail that sometimes we want. So we know some patients, for example, when they obstruct, they don't have these arousals during sleep. They just let their oxygen levels drop, okay? Then we see another group of patients that they have a mild obstruction. Their oxygen levels don't drop, but they have a lot of sleep fragmentation, right? Well, what does that matter? Well, it matters because if you are somebody relying on oxygen testing to diagnose sleep apnea, you might have missed those patients that have a lot of sleep fragmentation. Why else does that matter? Well, maybe those patients that have a lot of sleep fragmentation may have the cognitive implications of sleep apnea, whereas those that have low oxygen may have the more cardiometabolic aspects of things. So within the sleep study, there are phenotypic variations, but before that, there are phenotypic variations in what's causing the sleep apnea, which we've sort of spent our time talking about. It could be because of the airway size, it could be because of the tonsil and adenoid size, it could be the jaw, craniofacial features, it could be muscular features. For example, Dr. Landeo Gutierrez from our lab just recently published differences even amongst Hispanic and Asian children, that there was a difference in sleep apnea risk just based on facial phenotype related to race. So, maybe we need to think outside the box, not just look at the sleep study, but look at the patient and try to come up with the best treatment strategy. And there's a lot of stuff that still needs to happen. And I want to emphasize that those who are thinking about a career in sleep medicine, the wrong quality you want is somebody who's closed-minded. Because if you have a closed mind and don't think about all these strategies, then you're just missing the boat, in my opinion.
Yes, completely agree with that. This is such a great conversation. And I know we have to wrap up, and I have so many more things I want to ask you and talk to you about. So for anybody listening or watching, comment, please have Dr. Bhattacharjee back or share this video. And then I'll beg you to come back in the little amount of free time that you probably have, Dr. Bhattacharjee, because you're so busy. But I do want to go over maybe at a future time, non-airway factors, like ferritin issues, ferritin deficiency, and other issues, and how you might treat and when you CPAP in children. So that'll be saved for another time, but I really want to thank you so much for joining me. And yes, tonsil and adenoids are one important part of the picture, but we also have to think about the nose, craniofacial anatomy, weight and metabolic health, like you said, respiratory health, neuromuscular function, the individual child and the family. So I just really want to thank you for your time and all the research that you have put into the field so far. And I know you will be having much more to come. And it really helps everybody understand why some children have sleep disordered breathing and what treatments we could do. And your openness to collaborating with the dental team is just outstanding, amazing. And let's get together and come up with some easy tool that sleep medicine doctors can also look at in terms of craniofacial oral factors, a 5-minute quick checklist to add on to their screenings when they're seeing patients. And I think all of this work together is really just going to continue to better the health and the lives of children and their families. So really thank you so much for all of your time in doing all you do, Dr. Bhattacharjee.
Well, and I'm going to hold that to you, Nicole, because I know you're very passionate and a great educator, and if you can help my colleagues and fellows in sleep medicine in their approach to the mouth and understanding the phenotypes of the mouth better, I think we would be better sleep physicians. And I'm glad that you ended this discussion on the most important word, which is collaboration, because this is something that we all do together. And I think it's a real opportunity to improve the lives of all these kids that have sleep disorders.
This is awesome. This is wonderful. Thank you so much, Dr. Bhattacharjee. I'll be there next week at your office.
All right, sounds good.
All right, have a great rest of your day. Thank you again.
You too as well. Thanks, Nicole.
Thanks. Thank you so much for joining this episode of Airway Answers. I'm hoping some of your airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much and join us for the next one.